Well, today we have two beautiful ladies who've come all the way from the Northeast, absolutely fabulous. Dr. Elvira Parravicini, who is an attending neonatologist, and Frances McCarthy, who is the coordinator of Neo-Natal Comfort Care Program. They're from New York Presbyterian Morgan Stanley Children's Hospital. And you're doing an unbelievable work. But first, you beautiful ladies, Dr. and Frances, why don't you tell our family at home your credentials, who you are, where you were born and raised, and then we'll talk about your neonatal care program.
Sure, thank you. So I was born and raised in Italy, in the Milano area. I attended medical school there. I became a doctor there. I worked a few years, and then I moved to New York. I moved 22 years ago. And I just met the Columbia University Medical Center, and I did 3 years of training there, and then I decided to stay, and since I've been working there in this beautiful hospital as a neonatologist, saving baby's life.
Okay.
Wow. Beautiful.
And Frances?
I am a nurse. I was born and raised in New Jersey. I'm still a Jersey girl, but I have worked my entire career in New York City. So I was first a medical surgical nurse my first year, and then I went to the NICU in 1985 and stayed in the NICU ever since. And then in 2015, I became the coordinator for the Neonatal Comfort Care Program.
Okay, so then how did you two hook up? I mean, how did you two become one entity? Because you are an amazing team, and how God is using the both of you in the care of families that are in adverse diagnosis, right? They have an adverse prenatal diagnosis. What do we do? How do we navigate these waters? What does this mean emotionally, physically, spiritually? That whole journey. How did you two become one?
Right, so being a neonatologist, I take care of babies, and as I share with the parents when I speak with them during pregnancy, my mission is to save baby's life. Sometimes, unfortunately, we meet families carrying babies with life-limiting condition for which the life of the baby once he or she is born will be very, very short. And so I was concerned about what can I say to these parents? What do I do with these babies? I'm a physician. I need to stay with my patient, whether they live or they die. And so over the course of time, I tried to stay close to them, to follow them, to develop guidelines, a care for them. And in doing that, I don't know, we became more and more friends. She gave me suggestions. She came working with me after her hours during the day, and we basically built something together. I don't know if you want to add.
Well, I think working, you know, when you work in the NICU, babies are usually there for many, many weeks and months. And the physicians are on service for 3 weeks at a time usually, and often will become the primary physician for particular babies. So you have the opportunity to really work through what's going on with the baby, how we want the plan to be, whether this plan is working. And so in working with Dr. Parravicini, it became clear we had many of the same ideas and perspectives on how to care for children. And I think the other thing that happens is there has to be a certain level of comfort in speaking with families about difficult decisions or difficult situations. And that's not always easy for everyone. I wouldn't say it's easy for us, but I think there's an understanding of the need for the family to really know what's happening and what options they have for the care of their child.
So they may get this diagnosis when? You know, right before delivery or months before? Or what are the situations where you begin to say, hey, we're here for you, and bring the team together?
Sure. Often it happens very early in pregnancy, around 18, 20 weeks with the ultrasound, the anatomical ultrasound. Sometimes instead it's much later because women will be referred by other institutions. And so right away we evaluate the situation, and we offer our support to stay with them, to support them, to try what is possible for their babies. We always, in any of these counseling session, we always ended up saying, you never know. We're going to check on your baby when the baby is born, and sometimes we do have surprises. And so the diagnosis, the prognosis can be slightly different, sometimes worse, sometimes better. And so can happen anytime during pregnancy.
Yeah.
I think often families come to us after being really bombarded with the idea of termination, and that the idea of not terminating is so foreign to many people that when they come and talk to us and we actually congratulate them that they're pregnant and they're going to have this baby, there's a sense of relief that they haven't felt before, and that they feel as though someone's listening to their story, that finally someone looks at them and says, no, you're not crazy. We think that this is quite doable and we're going to help you do it.
Yeah. Well, you're contributing to building, as St. John Paul II said, to build, let us all together build a new culture of life. And when life and support are offered, that's already written on the hearts of people, isn't it? It's written on the hearts especially of mothers. If they can find a person or two that says, you're not alone, we're going to walk with you through this. Life is precious at every stage and phase. It's not based upon the health of that child or the condition of the child, although it's hurtful what you're experiencing. But this is about life. We're about saving children or accompanying them if they are going to pass on in a short period of time. Did this neonatal comfort care, and we're still kind of unpacking what that's all about, did this come about your kind of unique way of doing things at New York Presbyterian? Was there a vision for it and people sewed into it financially? You became a part of it, or was it really born out of your friendship and care and saying, how can we do this, walking with families through this and caring for this child, and then support rose up around it? What came first?
I followed her.
You followed her, and then
Her lead,
kind of the
absolutely.
resources followed you both? In terms of saying, hey, we think this is beautiful what you're doing. How can we better support this? We want to gather more people around you. So
Well, first of all, it was innovative in the sense that for what we know, there is usually no plan for babies with short life. And frankly speaking, when people talk about comfort care, even in the medical field, it means very straightforward, let the baby die. And so what we took at heart is that the lives of this baby are sometimes minutes, hours, sometimes days and weeks. And so we want to establish medical guidelines to support the life of these babies as long as they go, with normal means, bonding, keeping warm, feeding them, and work on pain management. And so we did establish innovative guidelines, and so there was something new was born in our hospital. And then this was out of my job as a neonatologist. And for Fran, she was partially supported by our institution to work with me in this.
when you say innovative guidelines, and really, frankly, when I think of hospitals setting their guidelines, sometimes it could be very scary or very good. And like you said, there's such an atmosphere of, you've got an adverse diagnosis, then this is the first thing they want to speak about is abortion, termination, which is really killing of that child. So when you say innovative guidelines, you're talking about when you get a woman in this situation or a family in this situation, there are guidelines for dealing with this adverse diagnosis. What are some of those guidelines?
Well, I think there was nothing before, in a sense that, yes, especially for the baby, there was no plan of care. There is no plan of care.
Plan of
And
care.
so we, reading literature and looking at our experience, we want to establish a plan of care focused on comfort. So how a baby is comfortable, when can bond with the family, when it's fed, when it's kept warm, and when it doesn't suffer. And so basically, we build up a sort of medical and nursing plan following these guidelines, which imply also that we change a lot of guidelines in the management of these babies on the spaces that we use to keep together mom and baby and the rest of the family. So many new guidelines or policies were born out of this as a consequence. I don't know if you want to talk
Yeah,
more
so
about.
initially, years ago, what would happen is the baby would be separated from the mother, taken to the NICU, and the mother would go to postpartum. But in these circumstances where intensive care, an intensive care unit really offers nothing to this child of great value, it's actually better for the child to be with its mother, and certainly better for the mother, for them to bond and be together, for her to possibly feed this baby, and to let this baby's life, however long it may be entirely filled with love. And so that's the difference, I think, in where we had to switch gears and kind of change our perspective, and then open that idea up to the nurses and doctors who aren't used to seeing it that way. And so it opened up an entire new perspective of, these are not throwaway babies, these are babies who have a life, and they have as much worth as any other child. And so how do we acknowledge that and honor that and embrace it, and really embrace life as opposed to the fact that this baby will die, because the reality is we all will die at some point in time. So it's really about life before death, and that, I think, is how we have to shift gears in our concentration.
And how did the medical community respond to that? Because you had to create policies, procedures. You had to create space, because in the past, babies were put in god-awful places to die. I mean, I've heard horrible stories from moms who in the past had situations like that, had their child removed from them. They never had a grief process. There was this immediate disconnect, as if that was the best thing to do. So how did the medical community respond?
Well, they responded really, really well, because what we are doing, not because we are doing, is really beautiful. There is a lot of appreciation from the families, but also for professionals, nurses, doctors, anybody who is working with us in the delivery room. They see how beautiful, how satisfaction comes out of that. And it's always a moving moment when these babies are born. And I think out of this experience, people love what we are doing and support what we are doing.
I think also the fact that we're there, kind of mentoring, supporting them, showing them how they can do certain things, what to say, what should you offer, to not be afraid to speak, to ask if a baby has been named and to use that name, to just jump in with both feet. And embrace the family as a family. They will need many of the things that you would give to any other couple and any other family having a baby. They're going to want the same things. And so that's really where the focus should be, more on what any other baby would get normally.
You've got a group that's setting policies, procedures, guidelines. So if you've got somebody who's been treated or diagnosed by somebody who's part of the hospital, or maybe they've heard from someplace else, when they finally who do they get to? They're not getting to the people that set up the policies and procedures. What group are they meeting with? Who are they sharing with? Who's part of that team? How does the diagnosis play into the preparation? Because different diagnoses mean different things for the baby and for the family. Who are they meeting with?
So the steps of the process are the OBGYN basically discuss with us cases, with us neonatologists. And among all these cases, there are cases of babies with life-limiting condition. In that case, I will start in general meeting the family and talking about the medical aspect. So is the diagnosis this, how long a baby will live, and all the possibilities. Because sometimes it's not straightforward, you have to go through steps. Second step, we have this family meet with the whole team, which is, aside myself, Fran, which is our social worker and our psychologist, sometimes our child life, eventually even the feeding specialist, because we want to share with them all the resources that we have for the family, for the baby. Families are so much surprises about this possibility to plan ahead of time every single moment as soon as the baby is born. But also, and maybe Fran can tell you better about this, we have a lot of resources during the pregnancy, because this woman needs to go day in, day out facing co-worker, facing the family with the baby who will not live long.
This is just so important. I want you to elaborate upon it, because in our dealing with, whether it's family members or people that come through our crisis medical center, having resources, options, a whole community gives you a degree of control with something that's totally out of control. This baby's, I can't stop this baby from dying here. But if they don't have all of that, abortion is the means of control. For many people, they say, this is the only option I have. They have no other option. That's the problem. And so they say, well, let's just end this. This is a merciful thing to do. This can end it for me. But it creates a whole other set of problems that God can intervene in and be merciful in. But speak again about what you're finding with the people who come, what you're giving to them, and what it means to them.
The other person I want to mention is our chaplain. So the spiritual care of these families is also important. And we try to make the visits piggyback on their OB visits, so we're not asking them to come more often. People are working, they have child care issues, but really to speak to what is important for this family. What do they need? Right. Do they have other children? What ages are those children? How can we help them speak to these children in a developmentally appropriate way? What kind of memory making can they do during the pregnancy? Because for some of these women, this is the only time that they will have with their child. To help them realize that they are parents already, even though the baby has not been born. And to really, again, to focus on life before death, because we don't know how long this child may live, and we have to go day by day. So really, it's very much a team effort, and in being able to see them multiple times throughout the pregnancy, I think it allows for them to feel very, very embraced and held. And that's really what we're hoping for. And then we're going to see them through the pregnancy, through the delivery, and afterwards.
We're speaking about Neo-Natal Comfort Care. It's neonatalcomfortcare.com. We want to hear from you. Is this an encouragement to you? Maybe share your story. We're going to take a break. We'll be right back. We want to hear from you. Don't go away. Well, ladies, let's continue this profound discussion. Something you were sharing, Nurse Frances, is this, sharing with the mother that comes or the couples or the families that your emphasis is life. That, we have life here until this child passes. Everybody dies, but now let's do life. And I mean, that should be the worldview. It's not the worldview for many people, but you're reintroducing this whole idea of life, and you're really appealing to the instinct, to the way of that mother who really wants to give life, who wants to nurture this life, and that's just really profound. So that's very much a part of your program and of what you're doing. Yeah.
Yes, very much so.
And they respond to it. They know it.
Absolutely. We had a situation of a mom having a trisomy 18 baby, and she was a little bit of a thing. And the night that she was born, she came out a little cranky and not too happy. So we kind of calmed her down, and Daddy was holding the baby for a while, then Mommy was holding the baby, and she looked at me and she goes, I think she's hungry. I think she wants to eat. I said, well, then let's try that. And the baby actually went to the breast beautifully. And because, of course, Mom didn't have any milk at that time and the baby looked hungry, we did give her a little bit of formula, about 5 cc's, about a tablespoon of formula. And then she went to sleep. She was very happy, laying on Mommy, and they went to their postpartum room. This was right in labor and delivery that this actually happened. And then the next day I came in, and asked about how she had fed overnight. She hadn't fed anymore. So I called our feeding specialist to come in. And she came in to see this mom. And so she was working with the mother, gave her another 5 cc's. I had come in, I was there with the nurse that was taking care of Mom and also a student, and we were watching the feeding specialist do her magic. And then I stepped out for a minute. When I came back into the room, my feeding specialist was just kind of standing there looking a little worried, and I said, everything okay? And she said, well, she finished feeding, but she's not breathing. I was like, okay. So I just came over, Mom's holding the baby in front of her, and I stroked her cheek and rubbed her back, and she wasn't breathing, and this is what trisomy 18 babies do. And I said to the mother, I said, she's dying. I said, this is her time. I said, just hold her close, tell her everything you wanted her to know. Pulled the father in, and we stayed with them until the baby passed. And then after that, I said, we're going to give you a little time privately, and we'll go outside. So we did, and my feeding specialist broke down crying, and I didn't realize it was the first time she'd ever saw an infant die. So I gave her a big hug, and I said, you did great, Catherine, it's okay. And she said, it wasn't me, right? I said, it was not you. This was her time. And one of the things that Catherine shared with me afterwards was the fact that that moment and the hug that I gave her to let her know that this is what it's about and that we honored this baby's life is what really kind of made her want to be a part of our team and to
Wow.
work with these babies. And she's been a great asset to us
Beautiful.
amongst all of our team members.
I think we have a phone call, Joy.
Ilona, welcome to At Home with Jim and Joy. Your question or your comment for either the doctor or for Frances.
For both, really.
Okay.
It's when I heard on TV about the Zika virus,
Okay.
and they were showing on the news, Chaplain, about how the head of a baby would look after it's born, after it's been Zika virus.
Yes.
And they were so afraid that a lot of women are going to be afraid now, thinking that some of their babies are going to be born with the Zika virus. They were showing that a lot of the kids, even before they're born, they give them the sonogram. They said the head looks all right until after the baby's born. And then they said that virus goes to the brain and starts eating on the brain. So that's what I was worried about. Is there going to be I'm afraid there's going to be like a pandemonium, about this. And some women might want to use that excuse to abort their babies.
Okay. Well, thank you for your question. So, I mean, that would be another diagnosis because of the Zika virus, and concern. Well, this is what this baby's going to look like. It's not, So, shouldn't you be allowed to abort in that case? Shouldn't you go ahead and do that? How would you deal with that if you had a case where that was a diagnosis?
Well, first of all, when we decide who are the candidates for the comfort care, we want to make sure those babies have life-limiting condition. A baby with the Zika virus is not a baby with life-limiting condition. His baby is going to be born with problems, and we need to set up the proper treatment for the baby, the physical therapy, the neurological assessment, and everything. But one thing that we want to clarify very well, the comfort care is for babies who have a short life.
Right.
So this is a baby that we, as a neonatologist, I need to take care of properly, help him or her. But we will support this mom who would come to us saying, this baby is going to live. We need to help him or her. And so we can even, we support anybody because in what is typical of our team, we do the impossible at the contrary of the impossible, in the sense that we are available in any situation. But in this case, it's not a matter of comfort care. It's a matter of help this baby go through life.
Right.
So really, this is what we need to share with our culture. It seems countercultural now. If there are, it's easy for me to say because I'm not in that situation, but yet we can't compromise. As the church teaches in living the gospel of life, that the premise should be that we never intentionally, willfully kill the innocent, neither do we collude in the killing of them. And I think that's just really important for us to get in our minds, so that when we're faced with these very difficult situations, that's a part of the formation of our conscience. So I can say, this is terrible, I want to run away from this. Maybe the thought went through my mind that this would be the way. It's okay to say all of that. But life, we don't have a right to directly take that life. And you're saying, this is a child that's going to live, in all likelihood, with complications. Life is complicated. This is a difficult, thing, but we need to move towards life. You have shared, as we were sharing before you came on, the importance of, I think you said, follow the child. So follow the child. Please explain what that means in terms of the diagnosis, going through the birth process. The baby is delivered. What do you mean by follow the child and what's happening and the kind of care that is given?
Sure. So, and this is my principle, the guiding principle in my medical activity with any child. And actually, I learned through this program how to use with everybody. So, a baby is born with a potential diagnosis. We always have to double check whether it's true or not afterwards. And so also when you have a diagnosis, is it possible that the baby will manifest that illness, that disease in different way? Each individual is different. And so although we are prepared sometimes to welcome a baby who lives for a few minutes, before the birth, we always share with the parents this expression, you never know. We'll follow your baby. We'll see how your baby will do. And some of them, they have very short life. Some of them present with very unanticipated reactions, sometimes very good. And so we do have several examples of babies that have been labeled with diseases regarding the brain. For example, I give you an example of a baby born with holoprosencephaly. This is a very big word, which means that the baby brain is really, really malformed. And if you read on the book of pediatrics, they say that this is not compatible with life. And so we follow this family during pregnancy, expecting the baby to have a short life. Well, this baby, and of course when the baby was born, he looks very, very active. So we feed the baby, we bond with the family, we send them home with the hospice. To make the story short, the baby actually lived for 28 months. Wow. Unbelievable, unheard. Why? Probably because his center of respiration in his brain was well developed, differently from the rest of the brain. And so we don't decide when a baby starts life, and we don't decide when the baby finishes life, like for each one of us. And so in this sense, we follow them.
Yeah. That's so powerful. So there's some diagnoses where the baby's not supposed to be able to breathe at all, or well, and the baby comes out and starts crying. He's saying, look at me, follow me, you know, and don't just label me this. And if you're not prepared for that, in some places, they're like, we really don't want to deal with that. And then, you know, the baby could just die instead of being cared for, living as long as it possibly can, and building that relationship with the mom and with the family.
We have an email. The type of care that you provide must be very expensive. Do you run into resistance from insurance companies and hospital administration? And this is from Martha in Tampa.
Actually, it's less expensive in the sense that we have many babies in the NICU who require many weeks to months, sometimes years of intensive therapy. That is very costly. Our babies are treated very simply. So their life is supported by how well their body can support it. So feeding them and keeping them warm and dry, going home if that's possible, and again, living their life in whatever way they can, not necessarily with any kind of intensive care.
Right.
So I think in that sense, it's no more expensive. You know, insurance companies pay for labor and delivery care and postpartum care. So in that sense, it's actually not.
Right. But if you had a child and we were following the child in a rare case where you're saying, well, this child seems like the longevity of the life could be more, then it could be a NICU case.
Yes.
Right. So that's the following the child idea again.
Sure.
You don't want to be doing things that, you know, it's an excessive burden. It's not going to be able to benefit to the child. The same thing in the last stages of our life. But you got to follow what's going on there and say, no, we thought we were here, but we're here with this one. It's a rare thing, but we're here, and you're ready to do that. That seems to be what makes your program so unique.
Yeah.
We've had babies that we initially thought were going to be comfort care, or we weren't sure. And it's not until they're born and they declare themselves that they say, well, just when you thought you knew what we were going to do, we're doing something different. So they got intensive care.
What could we do to make your program there at New York Presbyterian Hospital there, Morgan Stanley, not so rare? Are you doing anything with that? How are you sharing the word? You're at home with Jim and Joyce. Hopefully many will hear you. But I mean, what are you offering to others who might hear this and say, gee, you know, we want to hear more about your philosophy on this and how this happens? Is the word getting out?
Well, we are available, and we have been doing that, going around teaching. We do once a year a workshop. We started in 2011. A workshop for teaching. Is an entire day, is accredited for education, and we, all of us, so myself, my OB doctor, friend, the psychologist, social worker, chaplaincy, everybody will talk about what we specifically do. We go through clinical cases. So this is a very good way to spread the news, to teach. Our ultimate goal is actually to have this comfort care as the standard of practice for babies with life-limiting condition. Every hospital should do that. It's like you give antibiotics for a child with pneumonia. When the baby has a life-limiting condition, should receive comfort care. So we are available. People can come contact us and come to our hospital, come to the yearly workshop.
Frances, you are holding up. I don't know if the camera got it or not. Why don't you do that again?
Sure.
Are these a couple of brochures that you think helpful?
This is our brochure for the program, and this was the brochure for the conference that we just had about a week ago on the 24th of October. So we offer that to any professionals and anyone that's interested in doing comfort care. And then the program brochure is to let people know, families, other professionals, what it is that we do and the services that we provide for them.
And I guess you can go to neonatalcomfortcare.com and they can get that and all the other information. And I do want to say, again, what's going on at the hospital is not per se Catholic or Christian or Jewish or whatever.
It's human.
It's human, it's kindness, it's compassion, it's in keeping with what we think medicine is supposed to be about, with the human person. From the time you began this, meeting each other, more people rallying around, the acceptance of what you're doing and people getting on board, how is that happening? Is it through philosophical discussion, or is it through what they see or they catch it, or how is it that so many people from diverse backgrounds, maybe no faith at all? I think you could be an atheist or an agnostic, and so is that what you're seeing? What's going on? Why are people being attracted to this, doctor?
So I think the experience to be with us in the delivery room and seeing this mother and father holding their baby, so expressing their motherhood and fatherhood is a unique experience, which is moving for everybody. And so there is, I believe, a cultural change in our hospital towards welcoming this approach, because it's human, as you said. The parents that we follow belongs to different religion, and some of them, as you mentioned, they don't identify themselves in any kind of religion. But the possibility to be mother and father is such a value, because it's part of what we are as a human being. And so even the professionals present on those moments, they learn by experience that this is a value and we need to support this value. And so there is, as I said before, a cultural change for that.
Culture of change.
Yeah.
Well, that's an encouragement. Your thoughts on just how it kind of spread and was accepted, and what your hope is for the future of this kind of style of ministry in this way, this comfort care?
I think, again, death is a difficult thing to talk about, and certainly the death of a baby is hard to imagine, let alone to witness. Yes. And so by being there and not being afraid and having other professionals recognize that there's beauty and grace, even in the moment of death, is a huge gift to them, as well as it is to these babies and to these families. I think it opens up an entire perspective for professionals that they may not have had before, and certainly lessens the fear, and actually allows them to have the tools necessary to do something. There is never a time, and it doesn't matter if you're a baby or you're 110 years old, there is never a time when there is nothing we can do. What we can do changes. How we do it may change, but there is always something we can do. And I think that's where we have to change the way that we approach our care.
Well, Frances, Dr. Parravicini, thank you so much for your great and for your holy work. You can go to neonatalcomfortcare.com for more information. We'll be right back. Please don't go away.